Hello, my name is Alice Gutierrez, and this semester I've been doing my clinicals on the OBGYN floor. So my patient that I'm going to be talking about is not only a well woman problem, but she is also pediatric. Um, so the patient I'm going to present is a 14-year-old female who presents to the OBG or the GYN clinic with chief complaints of cessation of her period. So history of present illness is this 14-year-old female is a gravida 0, presents to the clinic with her mother, and she states that she stopped having her period back in July of 2019, and the visit that I'm talking about is from March 3rd of 2020. So she hasn't had a period since July of 2019. History on her menses, she reached menarche at the age of 12, almost 13, and her periods were always irregular, occurring about every other month, up until July 2019, and then she just stopped. Not a period since then. No heavy bleeding has been reported, no painful periods when she was having them. She hasn't done anything to try to start her period. She hasn't been prescribed anything before, and she hasn't had any injuries or any changes to her health that she knows of that has contributed to possibly her cessation of her menses. She doesn't have any pain associated with like monthly ovulation, and she denies any stressors to her family and social life. So subjectively, past medical history is she's always been at least 95th percentile in her height. She did have febrile seizure when just a one-time occurrence when she was very young. Surgical history, she has had a left hip surgery. And social history, she is in the 9th grade. She lives at home with her parents and her 3 siblings. She plays the flute and is in the marching band. She denies any smoking, smokeless tobacco, vaping. She denies any alcohol use, and she denies any illicit drug use. Family history, there is breast cancer on her maternal grandmother, diabetes with her maternal grandmother. Diabetes in her paternal grandmother. Her mother and father both have high blood pressure, and stroke in both her maternal and paternal grandfathers. Review of system overall feels well. No unexplained weight loss or weight gain. She was a full-term birth. No developmental delays. Denies headaches. Denies difficulty swallowing. Denies any chest pain, shortness of breath. No peripheral edema. No wheezing on exercise. No nausea, vomiting, no constipation, no diarrhea, no abdominal pain, no changes to her hair, skin, or nails, no leaking urine or urinary burning, no unexplained vaginal bleeding or discharge, no unusual rashes or lesions, no difficulty walking or pain in her joints. Physical exam reveals that she is a white female who appears stated age, in no acute distress, and she was oriented to person, place, and time. She was a good historian, dressed appropriately for her visit. Her breasts are Tanner stage 4. No hair growth on the chest was visualized. Normal sized head shape, no hair growth on her chin or upper lip was noted. No thyroid megaly or lymphadenopathy. Heart rate was regular rate and rhythm. Lung sounds were clear to auscultation bilaterally. Her abdomen was soft and non-tender. No rebound or guarding, no organomegaly. She did, however, have male pattern hair growth to her abdomen. Pelvic exam, external pelvic exam shows male pattern pubic hair growth with normal labia minora and majora and no clitoral megaly. Her height and weight at the current visit was 99th percentile for both. She does have a BMI of 33.2, and so with that information, the doctor did diagnose her with amenorrhea and female hypertestosteronemia. So the mother did bring labs from an outside facility that showed testosterone was abnormally high of 139. Fasting insulin was high as well of 70. Her estradiol was very low, essentially non-existent of 0.01. And she had a normal TSH level and a normal FSH levels. So the doctor plans on obtaining urine to test for gonorrhea and chlamydia, which is according to the standard CDC guidelines is what we would do. Testing for trichomonas and pregnancy as well. And we are also going to send her to the lab to have some adrenal testing done, DHEA sulfate and 17-hydroxyprogesterone. And that is to test for any kind of congenital adrenal hyperplasia or testosterone secreting adrenal tumor. These are essentially the differential diagnosis. So the doctor is concerned for her bone strength and recommends that the patient starts birth control of levonorgestrel ethinyl estradiol to take daily to get her to start her period. And then concerns for her elevated insulin, we recommend that she maintains a healthy diet, increases her physical activity to suppress elevated fasting insulin levels. We also did a trans-abdominal ultrasound in the clinic, and it showed normal uterus, no ovarian cysts were noted. So we do recommend that she follows up in 3 months to kind of see how if the birth control pills have started her period, what the lab results come up with, and if they do result with any kind of adrenal abnormalities, I think it would be recommended that the patient be referred to a pediatric endocrinologist. So that also the doctor did note that it is suspect likely for this patient to be diagnosed later on with polycystic ovarian syndrome, but there will have to be some rule-outs, which is with the differential diagnoses that I just mentioned. And that summarizes this high acuity patient's pediatric and GYN visit. Thank you so much.